Okay, well, listen, good morning, everybody. I'm so excited to see you here. Here in Michigan, where I live, it's 8 o'clock. My name is Dennis Hammond, and I think it's about 2 o'clock in the afternoon for you in Italy on a great Monday. I'm so excited to be able to participate in this program uh, with Dr. Nava and all of the administrators to try to get some content out in this time of the COVID. And so I thought about one of the things that really affects my practice on a daily basis continues to be capsular contracture. And I've just been working very hard to update this entire lecture. And I've got some really cool concepts that I want to try to share with everybody today. So I hope that you'll find this useful. And let's get started. Just by way of disclosure, I've got what you'll see today are some mentor implants. And somewhere in here, I've got something. I have a consulting agreement with Mentor. I have a consulting agreement with Establishment Labs. You'll see some Motiva implants. And then I will be talking about it a bit about ADM. And I have a consulting agreement with MTF. So, what is capsular contracture really? I want to try to explain to you today is a different way to think about capsular contracture. And it goes something like this. For a given volume, if you wanted to try to maximize the surface area around a given volume, in other words, what's the most surface area you could wrap around a given volume, what shape would that be? And actually, it would be this. It would be a double ellipsoid, which is the shape of a red blood cell. And you know what? That actually makes sense because nature is so smart. The job of a red blood cell is to maximally present surface area to exchange oxygen. So there you have it. The maximum amount of surface area would be the shape of a red blood cell. Now, what's the opposite of that? What's the least amount of surface area that you can wrap around a given volume? Well, actually, that shape is a sphere. So the volume between these two is the same. It's just the surface area that's changed. So for a given volume, the smallest surface area that you can surround a volume assumes the shape of a sphere. That's just because of the laws of physics. So now we can apply that to the breast so that when capsular contracture occurs in an implant that's in a patient, because the implant is somewhat compressible, the surface area can actually change, but the volume is fixed. So the surface area has to decrease just by the laws of physics. So you go from here, which is a normal breast implant, you go over to here. And that's what happens when capsular contracture takes place. So you can see this demonstrated here. It's just a little bit the opposite. This is me filling a saline implant, and I just went from 175 to 225 cc's. Now I'm going to fill it from 225 to 275, and now I'm going to fill it from 275 to 325. So you can see here it's the exact opposite, and that's the surface area of the device can't really change, but the volume increased. But the same thing happens. It's the same effect. And what you'll notice is the projection of the device increases and the base diameter decreases. And we see that now when we take these implants out of patients. So this is a patient who had the exact same implant on each side. And what I did is here on this side, I cut the capsule away and then took a picture. And you can see then that as a capsular contracture formed, what happened was the shape went from this open implant here to this contracted implant here. And it's trying to assume the shape of a sphere. So now what happens is when you use different kinds of implants, the surface area can change. A round implant will follow this curve. Say an anatomic implant or one that's irregularly shaped can't decrease as much as far as its surface area is concerned. So that's the difference between round and anatomically shaped implants, but the same thing still happens. So if you have to ask yourself, what is capsular contracture? It's a capsule that forms around the implant. It usually results in a firm and superiorly dislocated breast. Usually it's associated with asymmetry, and it may be associated with pain. And as you've seen, this is what happens when you have the capsule form around the implant. So I've been doing some bench work now. So this is really the first time I'm presenting this experimental work. Can you develop a bench model for capsular contracture? And actually you can. You can take an implant, you can put it inside a balloon, and you can pinch the balloon down so that the rubber of the balloon mimics the capsular contracture. And then if that's true, you ask yourself, can the surface area of the implant in the capsule be measured? So how do we measure that surface area? What I tried to do is use two different methods, a surface coating method and then using 3D imaging. So here's our balloon, and we just open that up. We try to stuff the implant in there, and there's our capsular contracture. If we can pinch that down, twisting it down, then we can mimic the effect of capsular contracture. And just here's a little video clip that shows how we did that, actually. Just a very simple little bench model. We cut the end of the balloon off, and you can actually spread this open. You have to try it a couple times in order to see it. But if you've got a properly chosen balloon, we put a little lubrication inside the balloon like this. And we can take the balloon or the implant, and we can actually stuff it inside the balloon like this. And then what will happen is, because of the lubrication, that rubber will push on the implant very symmetrically. So if we massage that around a little bit, we can mimic the effect of a very firm, compressed capsular contracture around that implant. You know, we're moving the implant around a little bit, like so. And then if we take that now and we pinch it down like this and twist it as tight as we can, that will be the firmest capsular contracture that we could envision. So this is all the way. This would be a Baker grade 3 capsular contracture because it's maximally contracted, and we just tie that. And what we can do then is compare. So now here is a 320 cc moderate profile classic implant inside the balloon. Here's that exact same implant as it sits on the table. So you can see the real significant change that takes place when we take the implant and we maximally contract it. So this is just a demonstration of the exact same implant with the decreased surface area around it. Now, to try to measure the volume, what we initially did is we dipped the implant into a wax bath. We let the wax harden. We took the wax, cut it off like this. So you can take this wax off in segments. And we took it and we put it on a piece of paper. And then by tracing the wax on the piece of paper, you can then use a three-dimensional program to take the segments of the wax, diagram them out. And then what we did is we used this app. We found an app that actually is used to measure the surface area of leaves. And it automatically generates the surface area of each piece, which was really very useful. So we did that for a series of implants. You got to cut off the little pieces and measure them all. And we found that to be accurate to about 1% of the surface area that you could calculate just using physics for known objects, say like a pool ball or a tennis ball. And then the next thing we did is we took those same implants and we put them into a CAT scanner. And then we took and put each implant in a balloon and got a CAT scan of each device, including some known objects, such as a pool ball here. You can calculate the surface area of a pool ball. And we generated these kinds of images, like this. So when we compared the wax evaluation method and the CAT scan evaluation method of calculating surface area, because according to the laws of physics, you can actually calculate a surface area if you know what the radius is, which you do for a pool ball. You can see that the mathematical surface area of a pool ball that has a radius of 2.85 centimeters is 102 square centimeters. When we use the wax method to calculate the surface area, it was 102.3. And when we use the CAT scan method, it was 102.1. So really very accurate, less than 1% variance. So now what we did is we took a group of implants. We used group 1 with the moderate classic, the moderate plus, and the high profile, all of roughly the similar volumes. Then we used a new generation of devices that are filled just a little bit more, called the extra. So moderate profile plus extra and high profile, again, similar volumes. And then we used a group of anatomic implants. These are the Mentor CPGs, the memory shaped devices, the 312, the 322, and the 332. So that's the low height implant, the mid height implant, and the tall implant. Again, all of the similar volumes. And here's a photograph of all of the implants. And we calculated the surface area of each one of these devices as it lay on the table and as it occurred inside the balloon. And here's an example of, this is the moderate profile plus 325, and this is the moderate profile plus in the balloon. So here I think you can see the difference as it becomes more spherical once you put it inside the balloon. Here's moderate profile classic. So that's going to be a bit of a flatter surface area. And then here it is inside the balloon. So you can see the change in the surface area looks almost as if it would be more dramatic. And in fact, actually it was. Interestingly enough, nobody's ever calculated this number before. If you go from totally open to maximally contracted, and you ask yourself, what is the maximal change in this? What is the average change in the surface area that occurs for all of these various implants? It was about 20%. So you only had to decrease the surface area 20% to go from totally open to totally contracted. That, be honest with you, was a surprisingly small amount. That's the window that we operate in as we do breast surgery. If we get any degree of contraction of that pocket around that implant, it doesn't take much before it starts to deform that implant and create the phenomenon that we call capsular contracture. The other interesting thing here that you can see, this is a standard implant, the moderate classic, the moderate plus, and the high. The moderate classic, because it was a flatter implant, actually had more room to change. So it could go from flat to completely contracted. It was actually a 30% reduction in the surface area. But the high profile implant, which has got a higher profile, it's more circular to start with, only could undergo 18% change before you got maximally contracted. So that was curious and actually makes sense. Interestingly enough, the anatomic implants were all pretty roughly the same, whether it was a low height, a mid height, or a tall height device, they were all about 20% change. So overall, 20% change in the surface area. So that's what this says here, 20% change. So why is that important? It's important because of this. I've taken a look at the literature now, and if you take a look at the various descriptions of the Baker grade classification, they're all over the place. And that's one of the problems that I think that we've had with trying to talk about capsular contracture in the past. So this was the original Baker grade. It said that the augmented breast feels soft. Here, grade 2, it was a minimal contracture. It was less soft. The grade 3 was more firm. And the grade 4 was hard, tender, cold, and painful. This is totally subjective and really not very scientific at all. But back at the day is all we had. Spear tried to modify this in 1995. Gilbert in 89 modified it further, again, noting that it was soft with no deformation. Here, it was noted as slightly thickened consistency. I mean, what does that mean? There's another modification by Palmer in 92, same kind of thing, describing the contracture in terms of firmness and look. Here's one in Benedictson in 2006. Again, a modified Baker-Palmer. So we're getting more complicated here. Gosner in 2016. Again, trying to describe what it felt like and what it looked like. And then for reconstruction, it was modified further into these types of classifications. Then this was modified further by Lussing in 89 and 2001. And then Spear modified it further for the presence of radiation. And again, modified by Hirsch in 2012. All in all, there are 10 different published versions of the grade. All of them focus on look and feel, and they are totally subjective parameters. And I think that it's time that we do better than that. We've got to have something that you can measure clinically. And I really wonder if the Baker grade is the best way to go about doing this. So what I did in my own mind, looking at all of those various types of Baker grades, is organized it this way. A grade 1 looks soft, feels soft. A grade 2 looks soft but feels firm. Grade 3 looks firm and feels firm. Grade 4 is painful. Even this is not really very helpful because you can have a grade 2 that is painful. So now what is it, grade 2 or grade 4? The problem here is that capsular contracture presents as a spectrum of severity. And right now, the current Baker grading system is subjective and it's incomplete. And it really doesn't emphasize the physics of what is actually happening. And I think that we can do this. The physics of what is actually happening is the surface area of the pocket, as I've tried to show. So the question is, can the surface area of that implant and capsule be measured? Yes, it can. And can that surface area be used as a variable to describe capsular contracture? And I think that it can, because really what the volume of an implant is fixed. So as the surface area decreases, I think that you can develop a grading system based on that capsular surface interaction with the implant that incorporates pain. So here's how it works. If you think about it, the surface area of your implant here is fixed. And then as the contracture gets more and more, you start to see some changes. So the surface area of the capsule will gradually change until it reaches the surface area of the implant. So they're equal. Then as the capsular contracture continues to wrap itself around the implant, the surface area of the effective implant can actually decrease because an implant can compress. And it will go to the point here where it's maximally contracted, which is when it's fully the shape of a sphere. So what you can identify then is a zone here where the surface area of the capsule is actually bigger than the surface area of the implant. So the implant can actually move around inside the pocket. Then you reach a point here where it starts to get a little bit firmer, up to the point where the surface area and the capsule and the surface area of the implant are equal. That's what we call a 1. Then as capsular contracture begins to set in, can still be an acceptable clinical result, but it is a bit firm. That's what we call a 2, until finally you get to the end where it's just maximally contracted, and that's a 3. So how does this work now? This is a grade 0. The implant can actually move around inside the capsule. And this is what you see sometimes in your reconstructive patients. So as you know, when they lay down in reconstruction, every once in a while, you'll see somebody whose implant will fall off to the side. That's because the pocket is bigger than the implant. And here you can see we can move that implant back over. Here's just a video clip showing this. So you can see the implant moves over and then falls back. So the surface area of the pocket is bigger than the surface area of the implant. Up to this point, there's really been nothing to describe this. So we call that a grade 0 capsule. Here is an augmentation. So when we pinch the implant will actually move up like this. And as we allow it to fall back down, you can see that the surface area of the pocket is bigger than the surface area of the implant. This is not a bad place to be when you're dealing with an implant because the breast will be very soft and the only firmness will be the inherent firmness of the implant. Now, as capsular contracture starts to set in, the surface area will gradually decrease until the surface area of the pocket is the same as the surface area of your implant. And this is actually still a good place to live. The breast will still be soft. This is a 330 cc anatomic implant. And it was about the same. The pocket and the implant were about the same. But when that happens, we call that a 1. So now here's the combination in this particular patient. You can see that this implant falls all the way off to the side like this. So the surface area of the pocket is bigger than the surface area of the implant. So it can actually move all the way over. In this patient, this was actually a problem. We're going to go to the operating room and we're going to try to fix that. Close off that pocket so that implant can sit in there just a little bit. So again, that's a 0. So now on this side, actually, the capsule is contracted a bit. So the surface area of the pocket and the surface area of the implant are roughly the same. So there's been a gradual decrease in that surface area, and that's what we call a 1. Here's another
So
example
here
of
we
this.
now, after the removal of the expander and placement with our Motiva implants, and as we examine this side, we can definitely get that implant to move up, and there's a space, and the implant falls back down in there. So that means that the capsule is bigger than the implant. That's a Hammond grade 0. On this side, it's still soft, but it doesn't really slide up. It's just barely there. So the capsule is about the same size as the implant. So that's a Hammond grade.
So you can see you can use this now to catalog these implants. Here the implant moves around. So that's a 0. And here on this side, doesn't really move. It's still soft, but that's a 1. Now, as capsular contracture continues, now we've got a problem, because what happens is as the surface area decreases, the base surface area decreases, the base diameter will decrease, the projection will increase, just as I tried to show with that salient implant video when we started. And now you'll start to see the implant begin to form wrinkles. So here's an example of this.
So here we are. Now we're 2 years after our final placement of an implant in our bilateral breast reconstruction.
And you can see that this side is going to be a
then we place the
0
in this
relationship.
Case, a 450 cc, a high profile, a silk surface silicone gel implant. And she demonstrates an interesting finding here. Now, so on this side, she has what we would call a Baker grade 1. It looks soft and it feels soft. But in the surface area classification,
you see that's a 0. We can move that up, and the pocket is bigger than the implant.
Which means that the surface area of the pocket is slightly bigger than the surface area of the implant. So the implant can actually move around a little bit. So for that reason, we would call this a surface area or a Hammond grade 0. So on this side, it's a 0. On this side, we've actually had just a hint of contracture take place. And as we squeeze this, the implant doesn't really move, so it's not a 0. And it feels mildly tight, so it's not a 1. It feels like the surface area has contracted a bit more so than the surface area of the implant, but it certainly isn't maximally contracted, which would be a 3. So by default, it's not a 1 or it's not a 3. Basically, that's how you identify 2. So this would be a surface area or a Hammond grade 2.
Now, it's important to realize, as we showed, when you've got these irregular shaped implants, they can't contract down quite as much as a moderate profile classic. As we showed in the study, get to about 20% contracture. So they're not going to be able to contract as much. And that's one of the reasons why with the anatomic implants, the capsular contracture rate was shown to be very low, because you can still have a little bit of capsular contracture, which is what this patient demonstrates. But because the implant is resistant to the formation of that scar, it doesn't really distort the breast. So you can still survive that degree of capsular contracture with an anatomic implant. And then finally, when you get maximally contracted, this is where the implant folds and wrinkles and really assumes the shape of a sphere. And so that's what we've got here. You can see this is the implant
with our patient,
completely contracted. And if it's painful, we call that a B. So no pain is A, pain is a B. So pain means it's a 3B. And that this lady here,
a patient who has some long-standing implants in place, and she demonstrates a Hammond grade 3 capsular contracture. And by the way, is this painful?
Yes.
Yes.
So she just said it's painful. So that's maximally contracted. That means it's a 3B. I think that this way of thinking about capsular contracture is going to help us now communicate better across the spectrum of studies, because we're looking at the variable that's actually changing, the surface area. So here's just an example of a 3B. You can imagine how this would be painful. This is what we used to call a Baker grade 4. So when we take that out, that implant out, you can see that it's actually the form in the form of a circle. So grade 0, pocket surface area is bigger than the implant. Grade 1, pocket surface area and implant are just the same. Grade 2, pocket surface area has decreased a bit. Grade 3, maximally contracted. And if there's no pain, it's an A. If it's pain, it's a B. So here's the way that we think about that now. Grade 0 is almost this whole area right here, where the surface area of the pocket is bigger than the surface area of the implant. Grade 1 is just this very small area right here where they're the same. Grade 2 is where it progressively gets firmer until you finally reach the end result of capsular contracture, where it's maximally contracted. So the clinical break point really occurs between 1 and 2. I would say that 0 to 1 means no capsular contracture. 2 to 3 means capsular contracture. I think that'll be a very useful way to think about capsular contracture. So here is what I would propose that is used now to qualify or to grade capsular contracture. Grade 0, again, pocket surface area is bigger than the implant. Implant moves freely inside the pocket. Grade 1, surface areas are the same. Implant doesn't move, but the breast still feels soft. Grade 2, surface area is decreased to the point where it feels mildly firm. And then grade 3, maximally contracted. A has pain, no pain. B has pain. So here again, this is what we grade it as. And I've been using this now for a couple of years, and it's really very useful because when the patient comes back to see you at week 1 and it's a grade 0, and then they come to see you at week 6 and it's a grade 2, you can see that capsular contracture has taken place. And the variable that's changed is the surface area of the pocket. This can be clinically assessed, and you can recognize these changes over time. What we're going to do now as we move forward is we're going to calculate the surface area of implants like this, and then we'll know what the surface area of the implant is, and we'll be able to develop a scientifically determined amount of capsular contracture that I think will be very, very clinically relevant, because here we can measure the volume and the surface area using CAT scan technology. So now, how does that help us? It helps us when we try to develop ways to treat capsular contracture. Because, you know, there's a bunch of different philosophies of why capsular contracture occurs. Biofilm infections, seroma, hematoma, silicone gel bleed. And we've got strategies that we use, antibiotics, no-touch technique, textured surfaces, etc. A lot of us do this kind of a thing. We use drapes or funnels to try to protect the implant as it goes into the pocket like this, so that we don't develop a biofilm. But basically, capsular contracture is still going to occur. I'm just going to be very honest with you. I see these presentations that all of us have been subjected to. I've even heard people say that capsular contracture is a thing of the past. They never see it anymore because they use a particular technique, whatever. And I just don't think that that is completely accurate. I still see capsular contracture in my practice on a daily basis. So we've got to come up with a way to deal with it. Of course, the most certain way to deal with capsular contracture is to basically remove the offending agent, which is a scar. And that's in the form of a total capsulectomy. That's complete removal of the capsule. But stop and think about it for just a second now. In light of what I've just tried to present, what are we actually doing when we do that? By removing that layer of scar, we're restoring the pocket surface area. So you're restoring that optimal implant to surface area relationship, taking the scar out, and that's going to improve your breast shape. It will allow that implant to drop to the bottom of the pocket. So previous breast augmentation, a long time ago, in 1987, she presents what's happened here. The surface area has completely wrapped itself around that implant. This is what we would call a grade 3 surface area type grading system capsule. Our plan, go in, do the capsulectomy. What'll happen is that pocket will open up so that implant can drop to the bottom of our pocket. And this is the kind of capsule you can sometimes see with those old implants. They're calcified, very hard. These will actually crack when you squeeze them. The other thing they'll do is they'll put a fold in the implant. And what you can then is get little pinhole openings because of the stress that's put on that shell. But here we replaced it with the exact same implant, 250 cc's. And here the contracted side, so you can see the difference between the two sides. So here you can see with that contracted implant, we've got distortion in the upper pole. Here, because the surface area is now bigger than the implant, that implant can drop to the bottom of the pocket. The inframammary fold drops down because of the removal of the scar. And here she is now with a very nice restoration of a surface area to implant relationship, creating a very nice breast. And this is where we would want to live if we could. We would want to have that surface area of the pocket to be bigger than the surface area of that implant. She was subglandular, which is one of my preferred planes, actually. And so there's no distortion when she contracts. Another example, old implant, calcified dinosaur egg kind of shell. These capsules have to come out. You have no option for anything else. And when you do that, you restore a very nice relationship between the implant surface area and the pocket surface area. So this was a grade 3B surface area kind of capsule. She's now a grade 0, which is where you want to live if you can. Another example of this. Here you can see that surface area is maximally contracted. This is a 3B, or what we used to call an old Baker grade 4. There's that dinosaur egg that came out of that patient. And here's the change from open implant to contracted implant. So same kind of a thing. And you see all these different kinds of calcium deposits in these older implants, which tend to stress the shell, create leaks and ruptures. Here she was after that was changed out, with restoration now of the proper surface area to the implant relationship. You also see this now in augmentations as well. So here's a Baker grade 4 because it's painful, or what we call a surface area grade 3B. We can see that what we need to do here is restore that surface area. So we go in, we take out that, in this case, an anatomic implant with the double capsule. In the process of doing that, we'll drop that fold. And here she is 14 months later, restoring that surface area to that implant relationship. Totally soft. One of the areas where you'll see this real commonly is when you have a ruptured implant, because the silicone gel tends to be an inflammatory stimulus. This is a lady years after her previous anatomic silicone gel implant reconstruction. We're going to go in, plan to do our complete capsulectomy, and sure enough, that implant was ruptured. Silicone gel had leaked into the shell. He had a very profound double capsule formation here with this irregularity in the capsule. We sent this off for pathologic examination, of course, because this was a breast reconstruction. Here you can see that we replaced her with a 350 cc smooth round gel. So by taking the capsule out, we got out as much of the silicone oil as we could. We replaced it just with a simple smooth round gel, restored that surface area relationship with the implant that we put in. We created a very soft result here 2 years later. Another example of this, this is a lady we did a latissimus flap on back in 2004. The latissimus flap actually died on this side, so we ended up just doing the tissue expander. We just continued on with our reconstruction, brought her back, and we got a pretty reasonable salvage here with a tissue expander implant on this side, latissimus on this side. So this is way back in 2003. 2007, she was doing reasonably well. 2009, she was doing reasonably well. And now 16 years later, she comes back and she's contracted around that side where we just had the tissue expander without the benefit of the latissimus flap, which is something you can see. Well, we know what we need to do. We're going to take that scar out. We're going to fat graft. And sure enough, on that side, she had a ruptured silicone implant, which was a leaking gel into the capsule, probably stimulated the formation of that scar. Here we added our fat, put our implant in, and restored now a surface area to pocket relationship, which was the same looking from side to side, and greatly improved the shape of that device. So here's just a little video clip showing really a nice result now 17 years after her latissimus flap reconstruction. And when you can get that surface area of that pocket to match well with the surface area of your implant, you can really do some quality work. You can get that merging of those two constructs to really create very beautiful shapes. And again, what we're doing here is we're living in that zero zone. So this would be a surface area grade 0 capsule, so that when she squeezes, you see the implant will actually slightly move inside of the pocket. Now, one of the areas where you can tend to see capsular contracture occur is in patients who get a mild infection. So here's a patient that's had a previous vertical mastopexy. Here you can see the vertical scar. She's going to have a bilateral nipple-sparing mastectomy. So we used the tissue expander ADM wrap in this case. And here's the skin envelope for our mastectomy. We insert the combination of the tissue expander and the implant as a wrap. Got pretty reasonable result here at a week. We filled the expander up to 420 cc's, but at 6 weeks, she developed this bit of redness right here. We were able to survive this. We gave her some antibiotics, but she did set up a little bit of a capsular contracture on this side as a result of the infection. So you can see that this side is contracted a little bit. So the surface area of this pocket is a little bit less than the surface area here. So when we come back, we take out those capsules or score the capsule, tighten the skin envelope a bit. And unfortunately, 4 months later, she had a recurrence of that capsule. So now she's got an ADM in this side. What do we need to do? We can score it, but what we actually ended up doing just to completely remove any possibility of seeding of that capsule, despite the fact that she had an ADM in place, we completely took it out and got her to this point here. And so here she is. Now, once removal of that capsule, which included the ADM, which you have to do in this kind of a situation, we were able to achieve a nice result. So here she is with both breasts, I think, demonstrating just a really pretty relationship between the implant and the capsular surface area. So this is a grade 0 capsule. In other words, the capsular surface area is bigger than the implant surface area. So now that implant can drop to the bottom of the pocket and be very soft. So if we control the imprint, the footprint of that pocket, we should be able to demonstrate a very nice result. Here she's pre-pec, so there's no distortion. And then when she contracts, squeezes that implant up, you can see that is a grade 0 relationship. That's where we want to stay when we use implants. So just a beautiful reconstruction. She actually looks a little better after a reconstruction than when she started. So capsulectomy, very useful maneuver. The problem is a capsulectomy basically recreates the defect. And as you know, after you do a capsulectomy, you really need to put in a drain because that tends to create an effusion when you do this. And it's a scar-forming environment and you're a setup for recurrence. So here's this patient, grade 4 capsule. She's frustrated. She doesn't want to go back to the OR. She's even talking about removing her implant. And I said to her, listen, let's just go back and very simply do a capsulotomy. It's simple, doesn't necessarily require a drain. We put the implant back in. You should be back to work within a couple of days. And by capsulectomy, or capsulotomy, I mean this. We just go in and we checkerboard the capsule. We just make some cuts through the capsule like this. Here's another example of this. We just basically leave the capsule in situ and we just make these cuts. And you've got to make certain that you get through not just the capsule, but you get through the capsule and any scar that happens to be present in the soft tissue. This is what I teach my residents. Now, one person's capsulectomy or capsulotomy is not the same as the next person's capsulotomy because I think some people stop too quickly. So you've got to take that capsulotomy and you've got to get through the capsule and the scar, which is present in the soft tissue. So here you can see we're actually getting into the fat and we're not done yet. We've got to get all the way through. See, as I'm pushing with my finger, you can see it pop. We've still got one little spot right there, right there. That's what I mean. You've got to make certain you get that scar released all the way through. And you can actually accomplish the same goal. And what is that goal? Every cut, every capsulotomy causes that capsule to expand, and we're expanding the surface area of the pocket. And in a very simple way, you can go from here to here, just with a capsulotomy. And again, restore that same relationship between the implant and the capsule. And this is really an attractive option. It's simple, doesn't require a drain necessarily, and it can be quite effective. So, patient with a previous breast augmentation, we're going to do a little scar revision, but we're going to take out her old anatomic implants. We'll replace them with a round implant, just doing the capsulotomy, being very careful about where we put the footprint. You can nicely correct that capsular contracture situation here, restoring that relationship. Again, getting a grade 0 capsule. Same thing here, grade 0 capsule, just with a simple capsulotomy. We actually did this under local anesthetic. In a previous implant reconstruction, all we did here was a capsulotomy and an implant exchange. And we restored a really nice relationship between that implant and the soft tissue. Same thing here. All we did was a capsulotomy and a little bit of fat grafting. We got her to this point here where she came back and said, hey, she'd really be interested in a nipple reconstruction. So just with a simple capsulotomy and an implant exchange and a little bit of fat grafting here in the upper pole, we were able to restore a very nice reconstructive result, very simply. Same thing here, capsulotomy, implant exchange. Nice grade 0 capsule. Another example here, patient's undergone tissue expander reconstruction. She's got a pretty firm capsule around the implant. So we're going to go back. We're just going to capsulotomize the lower pole, fat graft, put our implant in, and we're able to reclaim that space to allow that implant to sit in and create a very nice grade 0 relationship. So the capsulotomy is an advantage because it limits the raw surface area, minimizes the effusion, releases the scar, and it's effective with really a very low recurrence. So now just a couple additional items. I'm just going to try to take 5 more minutes here. All of these are potential etiologies for capsular contracture, but the one common factor that they have is inflammation. Inflammation that then leads to contracture. And you can see that inflammation here. And a patient that's had a mastectomy, she's coming back, she's slightly red. This is not an infection. You see this very slow capillary refill with that little bit of edema that's present in the flap. That's inflammation. And I think that inflammation is a setup for capsular contracture. So we want to stop that inflammation. So we have an anti-inflammation medication regimen that we use. And basically very similar, simply it's prednisone. We give 40 milligrams of prednisone for 5 days. Then we give 20 milligrams of prednisone for 5 days, then 10 milligrams of prednisone for 5 days. And that little steroid taper limits the amount of inflammation which is present in the capsule. And I think that it helps prevent capsular contracture in patients that are going to be prone to develop that. One additional thing we do is we also give 10 milligrams of Singulair for once a day for 6 weeks. And that's an anti-contractile medication, an asthma medicine that really has very few side effects. So that's our regimen. We use prednisone and Singulair. And so here's an example of, again, why we give those steroids. Right after placement of the implant, here you can see that redness related to inflammation. And after 4 weeks, that redness is completely gone. So our treatment summary then is the antibiotics. Everybody in our practice gets antibiotics for any implant work. Pocket irrigation using a sterile protocol, the anti-inflammatory steroid taper. But despite that, capsular contracture remains a complication. So are there stronger medications that we can give? And I'm just going to show you just as a demonstration. I'm not advocating this, but I've asked myself, are there stronger anti-inflammatory medications that we can give? And this is what we call now our enhanced anti-inflammatory regimen. And basically what we do is we use methotrexate. And previously, methotrexate's been used for a variety of reasons. But basically, the effect of the methotrexate in the chemotherapy regimen was to block the effect of the anti-immune drugs. It was meant to limit the amount of inflammation which was present. So when you use this, you have to give folic acid as a coenzyme because the way that it works is it's an inhibitor of the various aspects of inflammation. What it does is it blocks folic acid. So it's very cheap, very easy to use. We even give this to little kids that have rheumatoid arthritis, juvenile rheumatoid arthritis. So we give it 15 milligrams once a week for 12 weeks. We also give a folic acid rescue, very common with the rheumatologists that use methotrexate, 1 milligram a day for 60 intervening days, and we rest for a day. We test the liver enzymes. We also use this with our steroid taper. So this was something we were just trying. This lady was our first case. She's had 9 implants, and I told her, you've got to have your implant. She's had 9 previous operations, and I told her, you've got to have your implants taken out. She didn't want to give up, so what we did is one last capsulectomy, horrible capsule inside. We put put her on her methotrexate taper, and she has stayed soft. This is operation number 10, and with the methotrexate taper, they're very strong, so the industrial grade anti-inflammatory treatment, she stayed soft. So we thought this was very attractive. We thought it was encouraging. So now with our real problem patients that have had multiple operations, we do the capsulectomy with the steroid and the singulair. And now we also give them the enhanced protocol. We'll go with the 12-week cycle of methotrexate, giving them 15 milligrams once a week. This is another example of one of those patients. 6 months later, totally soft, very beautiful result. And here's just a video clip of her showing she's maintained that relationship, grade 0 relationship, so that the surface area of the pocket is bigger than the surface area of the implant. And so we've got just a bunch of examples of this, but in the respect of time, what I think I'll do is I'll stop there. And what I'll do is try to open the chat room. And I'd like to just open this up to people that have various types of questions, if that's okay. So I'm going to just go ahead and read these. And I think that we've got about 10 minutes that we can use. First question here is, grade 0 can be modified or in a made way while dissecting a bigger pocket compared to the surface area of the implant. And actually, I understand the nature of this question. And that is a strategy that a lot of people use with their breast augmentations. In other words, they intentionally create the pocket when they do their breast augmentation to be slightly bigger than the implant. That actually makes sense. The problem is that we can't always control that pocket once you close the wound. So if there's any element of contracture that takes place, now you've got capsular contracture. But if you could fashion a way to make certain that that slightly over dissected pocket stayed there, we'd never see capsular contracture. That's why I think ultimately the treatment and really even the prevention of capsular contracture may be with the use of medications to help modify the formation of scar around that pocket. Now, previously, we've tried to do that with textured surfaces, for instance. And I'm a little doubtful that textured surfaces work in every circumstance. We've also tried to do that with antibiotic irrigants. We've tried to say, okay, if it's biofilm, we'll use antibiotic irrigants to try to prevent that contracture. Also, does not work 100% of the time. So, but it does lead into the concept. You're thinking correctly, thinking about the surface area of the pocket as we try to manage these patients that have implants put in. So thank you for that question. So what causes the shell of the implant to rupture or tear? When that capsular contracture wraps itself around the implant, what happens is the implant folds. And as that implant folds, what I'll try to do here is I'll use this piece of paper. Well, as that implant folds and as that wrinkle moves back and forth, if you look at that, you can kind of see that weak spot that folds in the shell. So as that wrinkle folds in the shell of the implant, over the years, that's a place of chronic stress. And as that stress accumulates over time, eventually that rubber will crack. And that's one of the reasons why when I see somebody that has a capsular contracture, I suggest to them that you might want to take care of this because it's putting stress on your shell, which is ultimately it will lead to capsular contracture. And the next question is, how often in your experience do you get recurrent capsule post-capsulotomy? And that is the question. The million-dollar question is that when we go in and we do these modifications, so we do a capsulectomy or we do a capsulotomy, how often does it reform? And I just have a number in my mind. It's just something that we've studied here on our own practice. It's about 10%, but it's variable. It really depends on what else are you doing? Are you doing antibiotic irrigation? Are you using textured implants, say polyurethane foam coated implants? People feel that polyurethane foam really helps. Are we using an anti-inflammatory medication regimen? All of these things feed into what is the recurrence rate afterwards. And this is where I think if you start to use, instead of the Baker grade, if you start to use the system that looks at capsular contracture in terms of surface area, I think we'll really start to get some answers to whether or not these modalities work. So does textured silicone really work? Does putting it underneath the muscle really work, et cetera, et cetera? Another question here is, when do I remove the implant? Well, basically, if the implant is compromised or if it's old. If it's older than 10 years, 8 to 10 years, I suggest they put a new implant in. And red breast syndrome. I think red breast syndrome does mandate an antibiotic, but you know what? If it's truly red breast, it's because of inflammation, we give them the steroid protocol, and that will completely take that redness away. And that's the same question here. Breast-related illness, BII. Oh, that's a whole nother kettle of fish. I don't know if we can talk about that here because the treatment for that is going to be capsulectomy with implant removal. I don't know if steroids really play a role in that. What do you about removing the capsule from the chest wall? My opinion on that is if the capsule comes off easily, I'll take it off. And you can actually remove fairly thin capsules, but if you're reaching the point where you're risking getting a pneumothorax, taking the capsule off, just stop. And you can either use scissors or Bovie, but if you're risking getting a pneumothorax, it's really time to stop. You don't need to do that. And what do I use to wash out the implant cavity? Of course, we use saline. You've got to get rid of all of the material, the oil and the dead fat and the red blood cells, et cetera. And you know, I'm going to make a confession to you today. I've got a series of augmentations going right now where I'm just using saline irrigation. Some people have suggested that antibiotic irrigation can actually select for resistant bacteria. So I've actually been using just saline irrigation, no antibiotic at all. And I have not seen a capsular contracture in a small series of breast augmentations I'm doing. So more on that perhaps later. And what's the difference between an intra and an extracapsular leak? Well, very simply, if it's contained within the capsule, that's intracapsular. And if it's broken through the capsule, that's extracapsular. That's why whenever I see a ruptured implant, I always suggest that implant be removed with the capsule, because you don't ever want to let the silicone oil and the gel leak outside the capsule if you can. Here it says, in your classification, grade 0 means that the pocket is bigger than the implant. Exactly right. In other words, it can be described as an implant malposition. What do you think? If it gets to be extravagant, if it gets to be too much. So as I showed in a breast augmentation, or sorry, a breast reconstruction, if the pocket surface area is so big that it will actually fall off to the side, that's a problem. That's an implant malposition. That's why in my world, what I try to say is that if you can have a pocket that's just slightly bigger than the implant, you would do that every time, because that's when you would have no capsular contracture. What do I think about half betadine and half saline? We've had panels on that here in the United States at our meetings, and actually that strategy doesn't really make bacteriological sense. The only thing that I know, even the triple antibiotic solution doesn't make bacteriological sense. There is a new irrigant that's become available now called hypochlorous acid that actually kills on contact. And all of the antibiotic irrigants that are out there, that is the only one that actually kills on contact. And you can Google that and get more information on that, I think. But for our problem capsules, we use that. And actually, if we have what we suspect to be an infection, we've used the hypochlorous acid. The trade name for it is phase 1. I have no conflict of interest with it. We've actually been actually able to salvage every infected implant that we've seen with it. These patients have drains in. What we do is we irrigate the pocket with the phase 1 after first irrigating with saline, and we've been actually able to completely clear the infection. Type of instruments used during surgery. Do they have any effect on capsular contracture? I think what you're meaning here is, does Bovie, the burn effect of the Bovie, have any effect on capsular contracture? I don't think so. Certainly I understand the concept. People are worried if you use the Bovie, you create a burn. It's not been my impression that that will actually increase your rate of capsular contracture, but that's something that certainly could be studied. Now, using this surface area-based capsule evaluation system, if you came to me and said that you did 50 breast augmentations with scissors and 50 breast augmentations with Bovie, and all of the scissors were 0 grade and all of the Bovie ones were 2 or 3 grade, I would believe you. That helps us speak in terms of the variable that's actually changing, which is the surface area of the pocket. And here's the question is, do you use polyurethane implants for recurrent capsular contracture? We don't have polyurethane available to us here in the United States. I remember back in the day we did, back in the early 90s, and people were very adamant that they felt polyurethane was helpful. And there, as you know, there are many European surgeons that also feel that polyurethane is very helpful. The unknown here is that polyurethane has also been affiliated with the ALCL issue. But that is very controversial. I know that with the Polytech people, they've noticed with their polyurethane implants, as of a presentation I just saw this weekend at the Barcelona breast meeting, they've only had 3 cases of it. So that's, a very low risk. So I think it's going to be up to each individual person to decide whether or not they want to try to use polyurethane foam-coated implants. So I think that brings us almost now to 9 o'clock. I think that was all the time that we've had. This was such a fun talk to put together. Capsular contracture is something that has been a very, very interesting subject for me. I still see it in my practice, and hopefully now with this classification system, I think that we'll be able to get to the point where we truly can make this go away. And I hope that you found that interesting. There's just one last note here. Somebody said ALCL association with PU-coated implants is controversial, cannot state that as an absolute. Well, actually, I can state it as an absolute. I mean, ALCL is associated with polyurethane foam-coated implants. It's just not very common. And what the true incidence is really hard to say. Like I said, with Polytech, with their implants, they've only seen 3 cases. The ones that came out of Australia were with Silimed. And so the Polytech people feel it's very important to separate those two. So just as a disclaimer, the Silimeds tend to, the polyurethane foam tends to break off more so than it does with the Polytech. So like I said, each person will have to use their own judgment as to whether or not that's appropriate or not. So I think then it's 9:01. Do we have? Well, thanks everybody much for tuning in. I hope that was useful, and I look forward to the day that we can all meet in person. I'd love to see you over in a nice location in Europe somewhere.